Kia ora raweri, tēnā koutou katoa. Yeah, that's me. Now, just to fill that out a little bit more, my mother was a language teacher, so I went to a French preschool when I grew up in England. How many of you speak another language? Fluently? Same number? Yeah. New Zealand's terrible. The number of bilingual people in New Zealand compared to many other countries is really low. And one of the disadvantages, or one of the big advantages of being bilingual is that you know that you see the world differently speaking from your other language, because it's got a whole load of different concepts, different things which are built into the language, which means that perception is changed just by that much. So it's possible for you to understand that there's at least two different ways of seeing the world. Whereas the risk is that you think that the only way of seeing the world is your own way of seeing the world. And that's really what I want to talk about today and expand out from. So Rawiri has explained a bit of my background. So I spent some time working in Waitara, learned a little bit of Te Reo, spent far too much time on the marae because I got involved with the Waitangi Tribunal hearings there. Then moved to Wellington, and Newtown Union we have in our practice 15% of our practice are white, are Pākehā. So we have a huge range of ethnic groups, many of them from a refugee background. And so my original idea in Waitara was that I could solve this problem of looking after people different from me by learning Māori, by immersing myself in the culture, sort of understanding how my Māori patients functioned. And I arrived in Wellington, I had a New Year's resolution to learn Samoan, but I never did. And then when I came to the 30th language, I might have learned a few words and I just gave up completely. So I guess where I'm coming from, and a couple of preparatory comments. The first is to acknowledge the work that Rawiri has done in this field from a very Māori perspective, and I really value and appreciate the work that you've done. I'm not doing that stuff. I'm not Māori. I've got some experience and background with Māori, but it's not my thing. The thing I'm really interested in is what things you can learn in a general sense that will help you dealing with all people who are different from you. So I think in terms of Māori cultural competencies, clearly an understanding of some of the Māori cultural values and beliefs is a helpful thing to do, and that's also true of many of the other cultures that you might interact with. But as a strategy for me at Newtown, on Monday morning it doesn't work because there's just too many different cultures if you're focusing on trying to know about all the different cultures. So this is really about a generic, what things can you do that will help dealing with all of these people who are different from you. I don't have any conflict of interest that I know of. This is a case I saw the other day. She was a 61-year-old Samoan woman, and she had it was just below her breast. It wasn't anything to do with the breast. And she'd rung up, spoke to our Samoan nurse. She speaks a bit of English, but prefers Samoan. And she rang up saying, look, I just need an off-work certificate. Can you do me an off-work certificate? And Flo said, actually, I think you need to be seen. And so she came in to be seen, but all she wanted was the off-work certificate. She came in with her adult daughter, and the nurse who did the triaging had found out that she had this abscess, that she was seeing the massage therapist, and that was being managed, and that she did not wish anyone to touch the abscess at all, that anything that had come into contact needed to be sent away and burnt, and that the massage was expelling the evil spirits. And so what do you do? So just hold that in your mind as we go through the rest of the talk, and then I'll return to it at the end of the talk and tell you what we did. So, culture. Ooh. So there's a whole load of definitions about culture, and I'll give you several that I've come across. But, this is one out of the Oxford English Dictionary, I think. So it's what ascertains to a particular social group, and may talk about the customs, the arts, the institutions of a particular nation, people or other social groups. So that's one definition. I like this one from Irahapati Ramsden, how many people are aware of Irahapati Ramsden's work? Sort of cultural safety, particularly within nursing, was where she did the bulk of her work. She's really well worth looking up, and in fact the nursing piece on cultural safety as the Nursing Council's statement on that is one of the better things I've seen in terms of addressing some of these issues. But so she talked about being a member of a culture surrounds a person with a set of activities, values and experience which are considered to be real and normal. So people who do things different from me and my lot are doing things that aren't normal. And people evaluate and define members of other cultural groups according to their own norms. So, that's a little bit of movement from the previous one. And then this is my favourite definition of culture, which comes in bits, I hope. Here we go. So, a dynamic system of rules. Now, that's really important. So, cultures aren't static. You can't do a description of what Māori culture is or Samoan culture is. It's dynamic. It's not all the same. Explicit and implicit. So some of the rules are written down, and some of them you only find out because everyone's doing it that way and you're not, and suddenly it's all a bit uncomfortable. Established by groups to ensure survival. I won't go into that, but I guess part of that is that these are pretty deeply embedded, involving attitudes, values, beliefs, norms, behaviours shared by a group, but harboured differently by each individual within the group. And I think that's also a really important point, that I may think of myself as a doctor, and I share a number of values, norms, and behaviours shared by doctors, but some of the things that doctors do I'm not that keen on, and others I do to a much greater degree. So it's not that all doctors are the same, they all behave the same. Some do doctory things much more than others. Communicated across generations, relatively stable, but with the potential to change across time. So I think that's a useful general run of things, but the next thing this author got on to talking about was that actually it's not too hard to describe my personal culture. I'm a bloke, I was born in England, I've learnt French as a preschool, I've become a doctor, I can tell you a whole lot of things about myself, I can talk about my values, my behaviours, my beliefs, and then as soon as you start making it into a larger group, so I'm a man, do I think like all men? No. There's a whole load of things about men that, yeah, I probably share, but as soon as you start making generalisations about me based on a particular group that I belong to, the less accurate it becomes. And so when you're talking about culture, it's a sort of a useful, sort of back-of-hand concept which has some utility, otherwise we wouldn't use it. But actually, it's not terribly useful if you're really pinning it down to the individual. So I think that's a really useful sort of starting point, and that's why I titled Caring for People Other Than Me. Fortunately, no one else in the world is just like me, and there are degrees of difference from me. Now, assumptions and ethnicity and culture. So do we make assumptions based on ethnicity? Come on. Yes, no? Someone say yes, of course we do. Anyone seen the movie Cool Runnings? About the Jamaican bobsled team? It would be just bizarre if you switched the ethnicities. So if the Jamaican team were precise and exact and obsessive compulsive about how they maintained their bobsled team, and the Germans were all laid back and cool and didn't bother about things. I mean, it just wouldn't make any sense, because we all know that Germans are like this and Jamaicans are like that. And the thing is, it's true enough for it to make some sense. And we had a house renovation done, and a German builder applied. And I thought, oh, this sounds good. Germans are precise and accurate, and he's exactly the sort of person I want to have as a builder. And I then did check out references and to see whether other people who'd used him had felt that that was also the case. And the point here is that we make these assumptions all the time, but you need to notice when you're making an assumption and go and check it out. So it doesn't mean that it's true, but if you had to take every person as a complete blank slate before you did anything with them, we'd be here all day. So we make assumptions all the time about people. Make assumptions about all the people here as being health professionals. So I can make some assumptions that these are all people who are reasonably articulate. They've all done secondary education, they've all done tertiary education. So there's a set of things I can assume about, which are probably true, but not always true. So yes, we do make assumptions. And I would argue that it has to be okay, because we're doing it all the time. But the question comes down as to what's the difference between that and racism? And racism is bad, of course. But what's the distinction? Well, it sounds like I'm being racist in my presumptions about Jamaicans compared to Germans. And I think the distinction is about intent. I'll go on to this a bit more. But so it's making an assumption which has negative connotations, which you presume to be true without checking out, and which is often based on a lack of knowledge as opposed to based on concrete experience. So I guess part of my thing with my German patients is patients and people I've had a contact with is that there are some national characteristics which happen with Germans, and my experience has led me to some of that. But you do need to keep on checking it out. I'm not going to go into any more detail about the distinction. There has been huge amounts of literature written about it, but I think the pretense that we don't make assumptions based on ethnicity and culture is a pretense. And I think to just say that anyone who makes an assumption based on a person's appearance or their gender or their sexuality or their ethnicity, to say that no one does that, I think is not true, and therefore we can't talk about it. Whereas, as you say, people do make assumptions sometimes, and there are times when that's not good. We can then have the discussion as to why it might not be good. Now, bias. We all have biases. It's normal, and it's what's built into the assumptions that we make about ethnicity and culture. And you can't get rid of it. How many of you have done the Harvard implicit association test? I'm sure you have. Anyone found these? Yeah, so they're really interesting. So what they do is they have it's a computer-based thing, and it takes about 10 minutes to do the test, and they have done huge amounts of validation, whole sort of stuff, and they can show that I am more comfortable with heterosexual people than I am with homosexual people. Now, rationally, I'm not prejudiced against homosexual people. I've got as everyone says about this sort of stuff, I've got a lot of friends who are homosexual. But actually, I literally do, and it isn't something which I have trouble with. But even doing that test implicitly, subconsciously, my world is wired because I'm a heterosexual, and that's how I think. And so when I see a patient in the clinic, when I ask them whether they've got a partner, what I'm thinking is, if I'm looking at a man, I'm thinking about whether they've got a female partner. If I'm looking at a woman, I'm thinking about whether they have a male partner, because that is the way my brain is set up. And I have to actively think about, hang on. And Ian Scott once did a session a long time ago, but when the HIV epidemic was just starting, he was saying, when you see a new patient, you should go up to them and say, well, so do you have a girlfriend or a boyfriend? And I said, it was something that just my implicit bias is that I find that more difficult than saying, have you got a girlfriend or a boyfriend? So the thing about implicit bias is that it's there, and if you're not aware that it's there and you're just acting it out all the time, you're going to create a whole load of strife, because the people for whom you have implicit bias against are going to get a worse deal than the ones who you don't have implicit bias against. And so having some self-awareness about where that sits with you, one of my female colleagues did these tests and was somewhat horrified to discover that she thought that implicitly she thought women's place was in the home looking after the children, which is the exact opposite of what she rationally says, but the implicit bias comes from all of that training that you get as a child as to what are the norms and values of your culture, and that all gets built into you. So if you don't have a sense of that implicit bias, you can't do anything to try and do something about it. The argument that Harvard says is they haven't found any evidence that you can change your implicit bias, as in that you can go from having this test positive to changing it to something else. I think you can do things to mitigate the effect of that bias. So if you're aware that, and I am aware that that's my sort of default take, if you like, in terms of sexuality, then I'm on my professional best guard to make sure I'm doing the best I can not to expose my homosexual patients to my implicit bias and do my best to relate to them as I would hope I would want to relate to them. The explicit bias stuff is, it's really up to you. Do you believe that everyone in New Zealand deserves good healthcare? Now, what about murderers, gang rapists, paedophiles? If one of those people, there are a lot of bad people. Do you believe they deserve good healthcare? Because if you don't believe they deserve good healthcare, you're not going to provide it. And you need to think about what your explicit biases are. And so, there are some people who believe that homosexuality is wrong. Well, don't go and work for the AIDS Foundation. you know? You need to try and be conscious of what both your implicit and your explicit bias is and work out how you're going to deal with it. Because the professional guidance and the professional expectation is that we will provide care to everyone. And my very strong view is that everyone deserves the best health outcome which is available to them. So the trouble is that biases will get in the way of that, and the bias happens both in terms of an individual level, the clinic level, the institution level, and the national level. And if we don't address those issues of bias, a whole lot of things would be self-perpetuated. And a really good example is bowel cancer screening. So they've done the pilot up here, great pilot, showed that it was good for white people, and not so good for Māori and Pacific. And if we spend money on the bowel cancer screening program, we will increase health outcome disparities. Now, if we believe that everyone deserves the same health outcome, any new funding we do should be spent on things where we're going to decrease health outcomes. So, and there are thousands of things we could spend new money on. I don't say that bowel cancer screening is a bad thing, but if we can't work out a way of doing it, which means that our health outcome disparities are diminished, I don't think we should be doing that. I think we should choose something else which will diminish those health outcome disparities because they are, as I'm sure you're all aware, large and I think untenable. And so this is the question of whether it's okay to give inferior care. And I guess I could expand that a bit more. It's not only giving inferior care, it's accepting inferior outcomes. And that's slightly different. It's not good enough to give the same care to everyone. Because there are some people who, in order to receive a good outcome, require more input. And I don't know how many of you have seen the graphic that they used for the college presentation around these issues that has the picture of the boys watching, it's an American cartoon, they're watching a baseball game and there's a fence and there's a little boy standing there and he can't see over the fence, and there's another one who's almost sees over the fence, and there's the tall one who can see over the top. And that's sort of health outcome disparities, and that if you put them all on a box, you give more to the little boy so that he can see the same as the big boy, whereas the big boy doesn't need a box at all. So it's that set of concepts. And you need to do that in your head, because actually what we're talking about here in terms of cultural competence is that the reason we need cultural competence is because of health outcome disparities. And defining cultural competence, I hate it as a term, it's horrible. But if I were to do a definition, it would be a circular one, which is when we have done everything to be culturally competent, we will no longer have health outcome disparities. So you can go where you want with that. Now, in terms of defining culture, so there are a lot of different layers. It's not just one set of items. And so these are some of the layers that might be there. So national culture, we're all New Zealanders, aren't we? Regional, ethnic, religious and linguistic cultures, so all of those who speak Māori share some cultural values, or any other language, for example. Those who share the same ethnicity may or may not share stuff. So ethnicity is an interesting one. I think the best example of that is the idea of the African American. And the US collects stats on African Americans. But I was visiting there last year and came across this concept that, you know what? There are African Americans and there are African Americans. African Americans are descended from slaves and have been there and have a huge legacy of really horrible things that have happened to them and a whole load of the consequences of all that has happened. And there are African Americans, like President Obama, who have African blood, who have come from Africa to the US. And whilst, if you define them by ethnicity, they are the same, their experience and their cultural expectations are potentially quite different. And so ethnicity, I think it's a really slippery subject and topic. And I think it's much more useful to understand someone's cultural background and cultural values than purely just their ethnicity. Ethnicity is vaguely useful if you're talking about genetic disorders which happen within particular ethnicities. And apart from that, I think it's fuzzy and of limited usefulness. Janelle Taylor wrote a wonderful piece about medicine as a culture. And if we go back to those definitions of culture and Irahapati's Ramsden's comment about being part of the culture, believe that you're right and normal, Well, that's us in medicine. Because medical knowledge is understood to be not merely cultural knowledge, but real knowledge. It's true, it's right. Best practice guidelines are what you should do. They're not just, this is my idea of what we should do, what do you think? They are a definition of what's true, and we know because of evidence. But bundled up in all of that evidence is a whole set of values and beliefs and attitudes and cultural mores that we ignore and pretend is just normal. And so there is this thing of, and the modification they did for the palliative care, the livable path care guideline was a really nice example of where they had this guideline and they tried to modify it by putting in cultural bits. And the trouble is that whenever you see cultural bits in there, they're sort of seen as being secondary to the real stuff, rather than just being another way of seeing things. So we in medicine are, I think, terrible at acknowledging different ways of seeing the world, at accepting someone who sees something differently from us as having a perfectly valid viewpoint that I disagree with, but actually we're in a diverse world. Fortunately, no one's exactly like me, and there will be people I disagree with. So medicine as a culture, I think, and then in terms of what is medicine as a culture, it, of course, varies a little bit around the world, and it's really, it's the extent to which we have been sucked in, if you like, to the American medical way of doing things, which is very hard not to do if we're using the literature, because a large proportion of the literature comes out of the US, and so the values and beliefs that come out of that get included within our New Zealand backing. So being conscious of the New Zealand culture of no culture. So, the ideal. Well, seeing someone who understands me means we can get to the nub of the issue much quicker. If they don't speak my language, it takes an awful long time without an interpreter. If they speak my language, but their social and cultural background is quite different from mine, they might be making some assumptions about me, which I then have to correct and point out, well, no, this is how I see the world. But if someone's exactly the same as me, then we can get to the nub of things straight away. And I hope you get by now that, fortunately, there's no one who's exactly like me. But the concept I'll point out in a moment is the idea of cultural distance. So there are people who are closer to me than other people. And so someone who's culturally close to me, I will find it easier to unburden and to talk about all the things that I feel are important to feel heard than someone who's culturally more distant from me. So that might be the ideal of finding a doctor or a nurse who shares your cultural background. The next one was what I was describing doing in Waitara, which was, okay, I had a lot of Māori patients, so how about I learn te reo, spend time on the marae, trying to understand some of the values for Māori, and, that helps. My te reo's lousy. I started learning it about 6 times, and I don't use it enough to ever get past a very, very basic hump. And without being fluent in the language, I really don't get a whole lot of the concepts. And whilst I think this strategy is possible and is something worth taking on if, for example, you were going to move to Samoa to work there for your life, for me in Newtown, it's a completely useless strategy. And so this is why I think, because of the diversity, we need to look at these cultural general competency skills. Now, I like this idea. This comes from Peter Singer, who developed it to talk about animals, but I think it works very well when we're talking about other things. So the idea is that if anyone come across the trolley experiments, Trolleyology, there's a whole literature about Trolleyology. There's a trolley and it's going down a railway line, and there's 5 people tied to that track and 2 people tied to that track, and if you switch the switch, only 2 people will die and not 5 people. And there's great ethical debates about whether it's okay to turn the switch or not. But the point about all of this really is just saying that there are people who are more important to me than the rest of the people. And if you had a line of 10 people along a cliff and only 3 of them were not going to be pushed off, I don't care who the other people are, that'll be my wife and my 2 children. Because that's the center of my moral circle. And then extending out, and this will be different for different people, but this is how I see it. So my extended family might be the next lot. And then by and large, my ethnic group. And then, I think of myself as a New Zealander, and I feel a lot about how we as a country do stuff together. Citizens, so people who belong here, How do I feel about the million tourists who come to New Zealand? Well, mostly I'm very happy to include them in my moral circle, but I probably think a bit less about them than I do about my family and anyone in the world. And that, in a sense, is our modern dilemma, is that we actually have to think of ourselves as a citizen of the world, because until we do, we ain't going to do nothing about Zika virus, because all the pandemics come out of the poor bit of the centre of the planet who have no health services. And so if you want to stop that, the only way you're going to do it is by improving the lot of those people and living in those areas. The Ebola virus, the Ebola outbreak, there is no public health unit in West Africa to respond to a potential pandemic. So don't be surprised if you'll get another one. So if we really want to do something, what I'm saying about it being unreasonable to have health outcome disparities in New Zealand, actually if we think about that on a global level, it's the same sort of issue. So I think you need to consider that. And different people see differently. So some people think of they're only concerned with a very narrow group of people. Other people, I have once met a man who truly had an international perspective. Joseph Tuanuku we visited him in the Solomon Islands when we had our honeymoon actually, and he was leader of the opposition at the time. He'd done training in Denmark, he'd been involved in international organisations, and his perspective was truly global. Most people don't manage that. So cultural distance is greater between me and those outside my moral circle. If my moral circle is small, and presume that you're a member of a fundamentalist religion, then people outside of your religion, and my house in Wellington is close to, or my parents' house is close to the Exclusive Brethren's worshipping place, and my father, who's got some really fine attributes and some that aren't as fine, was very pleased to be close to this because it meant he didn't have to talk to his neighbours, because they're not supposed to relate to people from outside of their religious sector, and he didn't want to talk to his neighbours. But so it means that the number of people they relate to is relatively small. And it might mean, and Joseph's other name I can't remember, GP in Nelson, who was reported in the media to say that he will not provide contraception to any woman. He's a practicing Catholic, and that is his view about what he would like to do. And it just means that people who disagree with him aren't going to get very good care from him, because he's got a smaller circle. He doesn't believe in accepting a value about contraception that's different from his own. And then, I might see all doctors within my circle, even if they're within a different ethnic group, or, it's a complex picture. But I think the idea of cultural distance is a useful one to then put into Monday morning of, if you're having difficulty with a consultation, noticing, so is this person like me, or how great is the cultural distance? And in terms of my work at Newtown, I think the prototypical patient who's the furthest from me that I've ever met was the Somali woman, Muslim, illiterate, nomadic camel herding person who spoke no English. I'd have no idea how she lives her life, what she values, how it all works. And in some ways that's easier, because I don't make any assumptions. So I have to ask everything. And I remember one occasion when you probably haven't noticed this, but all of the symptoms that our patients tell us about all appear in the indexes of our medical textbooks, because they're all acculturated as to how to speak in medical speak. And so one day I just out of, whim, one of my Somali patients through an interpreter said he had a headache. And I thought, oh, so what do you mean by headache? And he said, I've got flames coming out of my head. I thought, ooh, what's the differential diagnosis of flames coming out of your head? And tight pain, heavy pain, flames coming out of your head doesn't appear in our lexicon of headaches, but it does in his. So that thing of how far apart, just, as I say, on one level, the ones who are culturally most distant from you, you're on your guard and you're going to do everything you can. And the ones that you think are very like you, may be the ones you're most likely to put your foot in your mouth with. And the most memorable occasion I had was when we were still doing our own nights and weekend call, and would occasionally go out and do home visits, and I got called to a woman's house who had some low abdominal pain, and I examined her. She was quite tender, and I asked her whether she was sexually active, and she said yes. And I thought, oh, this could be an ectopic pregnancy, and so I thought we needed to pop it through to ED and get that excluded, and so I think we need to go to ED, and have you got transport, or you want to organise an ambulance? Actually, I'm going to drive past. And they said, oh, would you like to ride? Oh, that'd be great, thank you. So she got into the car with her flatmate, woman who was sitting in the back, and as I drove along, I thought, I think I know who she's sexually active with. And I think I've just put my foot in my mouth. And I did confirm this later, and we had a laugh about it, because she, of course, didn't have an ectopic pregnancy. But I just presumed that she was heterosexual, and she wasn't. And just be aware, so I saw an Ethiopian woman the other day who, she's quite stressed, and she was worried about a whole load of medical things. She was quite sure she might be having a heart attack, and whether she had problems with arrhythmias and so on, because she's training as a nursing student in English, which she learnt 3 years ago and is not her native tongue. And she's got 3 preschoolers, and she's stressed. So the thing about being within a foreign culture is stressful of itself, let alone all the other things that are added on top. So just be aware of the effect that has if you're outside of your own cultural norms. Values based on culture. Now, I've been using the time up a bit here, so we might move a little along. Have any of you done the CALD Cultural Competence e-learning module? A few of you? So some of this is in there. This is the work of Gert Hofstede. And I like this because it's value neutral. So it's just describing what people are, how they value a variety of parameters. So what this is a survey that initially he did with IBM staff on 116,000 people, but they've been doing this for the last 30 years and adding more survey data to it, and categorizing them by people, and then determining on these 6 factors as to where they rank. It's clearly less useful in settler societies, so making a presumption that New Zealand, Pākehā New Zealanders share the same place on these variables as Māori is an unreasonable assumption to make. So if there's a heterogeneous population, it's less useful. It is the basis of how we do racial stereotyping. And I think the usefulness of it is just to know that it exists, and I'll explain some examples as we go through. So power distance index is the extent to which the less powerful members of institutions and organisations within a country expect and accept that power is distributed unequally. Now, when I first arrived in New Zealand as a lad in 1970, the Prime Minister's phone number was in the telephone book. And there were episodes when Keith Holyoake was rung in the night by someone who wanted to talk to him. That would never happen in Malaysia. So this is a descriptive thing of actually how countries expect to behave. The first place I found this useful idea was, anyone read any Malcolm Gladwell? And this was from Outliers. And he told the story of Korean Airlines. And Korean Airlines were killing passengers by crashing planes at a rate that was so high that the Canadians were about to ban them from their airspace. And so they were doing a whole lot of research as to why this might have come about. And what they discovered was that the plane was far more likely to crash if the captain was flying than if the first officer was flying. And what they ended up attributing it to was that the Korean language has 6 different levels of familiarity in terms of how you address people. And it has so it's quite, I haven't put Korea on that list, but it's pretty high up in terms of the power distance index. And, short story, what they worked out was they thought that was what was causing the problem and they had cockpit recorders, and if the captain was flying, they had one where the captain flew the plane into a hill outside of Guam, and along the way, the navigator says, it's raining out there. Shame the radar's not working. Boom, they're all dead. Whereas if the first officer's flying, the captain will tell him what to do, because there isn't the same hierarchical expectation of being polite and being reserved and not criticising your elders and all of that sort of stuff. And so what they did, they went and decided that the cockpit language for Korean Airlines would become English. So it gets rid of all of that layers of formality. And it's not as bad as it sounds in that the language for air traffic control is English. So they all had to know some English for doing air traffic control. And so they introduced that, and they got Korean Airlines back up with everyone else in terms of safety and not crashing planes. So that's where I first came across this set of ideas. So that's the power distance index. And the idea here is just that there's no value attached to this. It's not saying Malaysia is bad and we are good. But it is saying that if, and hang on, we'll keep going, I'll tell some other stories later. So uncertainty avoidance, and this is where the joke about Jamaica and German is based. You know, they're very tolerant of uncertainty in Jamaica. As opposed to, it's interesting that Greece and Portugal are at the top, given that their economies fell over in the GFC. So again, you know, we're reasonably tolerant of uncertainty. And the thing is that if you're working with someone from a culture who is not tolerant of, is differently tolerant of uncertainty than you are, then you're going to have to do something different. And checking out how tolerant someone is obviously is important, because if you're going to prescribe statins, you're talking about risk. You know, how much risk are people comfortable with? So that whole idea of risk is a culturally bound thing, and you need to know where that individual might be from. And the point of use of this is saying, okay, so if it were a Belgian person, you might think, the odds of them being very tolerant of uncertainty is higher, so they might be more likely to want statins. Let me check out if that is true. Because they might be Belgian people who just hate Belgium because they're so intolerant of uncertainty. That's why they've moved to New Zealand, and as an individual, they might well be part of us, if you like. Individualism versus collectivism, I think, is a particularly important one. So the individualism pertains to societies in which ties between individuals are loose and everyone is expected to look after him, herself, or her immediate family. And collectivism, as its opposite, pertains to societies in which people from birth onward are integrated into strong, cohesive in-groups with thought which throughout people's lifetime continue to protect them in exchange for unquestioning loyalty. And so that's a really important distinction. And within New Zealand, you know, clearly Māori as a cultural group are much more collective than prototypical Pākehā New Zealanders. Masculinity index, and this is, you need to read the definition, it's not about being masculine, but it's about a society being called feminine when emotional gender roles overlap, as opposed to a society where the gender roles are clearly distinct. Yeah, thanks. So in summary, the point about all of this is that all cultures differ on, you know, that, for example, those set of values, there's variation, and my view of the world is my view of the world. It's not the right view of the world, it's just my view, and you need to find out what their view is, and you need to work out what you do about the fact that your view might differ from theirs. You can look at this stuff. This is just definitions from the New Zealand Medical Council Guideline on Cultural Competence, but this is what it's all talking about. So you need to be able to be respecting your patients and an understanding of their cultural beliefs, values, and practices. Now, I spend some time writing and teaching ethics, and one of my fundamental problems is with the idea that there is a universal ethic, that there is such a thing as the right way of doing anything, and if only we analyse a problem enough, we'll find the right way, which is born of medicine being right, or maybe medicine being right is born of that ethical view. I think that's completely wrong. I think what is right and wrong is culturally bound, and that we need to look at this ethnocentrism thing versus the cultural relativism. That the attitude that other ways of doing things are different but equally valid, and we need to understand the behaviour in its cultural context, I think is the way we need to approach ethics. So if someone disagrees with you, it doesn't mean they're being unethical. It might mean their view of what is ethical is different from yours, and your job is to find out what that difference might be. Anyone who wants to read a bit more about this, I really like the work of Biko Parekh, who's a Indian-born British Lord of the House of Lords. I think he's still alive, he's in his 80s. But his book around this is one of the best things I've written around this stuff. And he argues the argument about about ethics and what's right, and whether universalism is a useful approach particularly well. So if you're interested in following up that's the useful one. Now, I won't go into great detail about this, but basically the idea of explanatory model is a really useful thing. So just because I call the woman's problem as being a staph abscess that's caused by a staphylococcus that needs dressings and antibiotics, it doesn't mean that's the only way of seeing it. And if I don't understand my patient's model of it, we can't then work out what the treatment regime that's going to be effective is. If I think antibiotics will fix it, but she doesn't, she won't take them. So I need to understand whether that's what's going on. So, therefore, the aim of the consultation is to develop an explanatory model of the problem that we share. Now, that might be hard. I don't believe in evil spirits coming out of wounds. Doesn't mean I can't share an explanatory model and acknowledge that that's what my patient thinks is the case, and then agree on a management plan which includes her beliefs as well as mine. And it doesn't mean that you have to agree. So I have come across patients, as I'm sure we all have, who don't think that immunisation is good for their children. Well, I don't agree with them, but it doesn't mean I can't work out what we're going to do about that issue, and that a lot of it is about respecting them and developing a relationship, and if you can do that, the odds of it shifting is much better than if you tell them they're wrong. So, going back, last slide, going back to the case, so what happened? Her adult daughter was interpreting and was being a great cultural broker in that she knew that I was a bit uncomfortable with this whole idea and was a bit embarrassed about her mother's socially unacceptable view about what she ought to do. So that was really helpful. And so I might have, if I'd had my own run of things, I might have said, well, actually, she needs to be admitted to hospital for intravenous antibiotics and regular dressings to get on top of this because I'm worried that she might become septicemic and die. But that wasn't going to happen because if she'd gone to hospital, they might have gone, but as soon as someone had dressed it and done something they didn't want, they would have self-discharged, and then we probably never would have seen them again. So I had to reevaluate, so why do I think that's the right management? And actually, she wasn't toxic. There were no satellite lesions. She'd had it for a chunk of time without being unwell. She was happy to take some antibiotics. I thought about asking if she could come in to see it again the next day, but they had come in that day by train from Porirua, bus to Newtown. It'd take them 45 hours to get there, and just asking them to come back seemed a bit onerous. So I said, okay, well, let's do this. But we rang her a couple of days later, and, please, this is the things I'm worried about. And the way that I hold the consultation is say, if it was up to me, this is what I would want to do. I acknowledge that this is what you want to do. We need to work out what in fact we're going to do and work out what the issues around it are. The reason I think this is because I'm worried about this, this and this. I appreciate the reasons that you're concerned about that is because this and this and this. How about we do, and then do the negotiation. And the negotiation may end up with a management plan which doesn't fit best practice, but it may be one that she'll follow through. And so the outcome was that a week later, she rang our clinical pharmacist to ask for a repeat prescription of her antibiotics. And the pharmacist said, I think we probably get to see you. And so she came in, and in fact, the whole thing had cleared up very nicely and probably didn't need any more antibiotics, but I gave her some really just because she thought she needed them and I thought I'd make friends. And so she went away. Now, I'm confident that in future, if she has another one like this, that she will come and see me. Because she knows that she will be heard, that I won't tell her off for what her beliefs are, that we'll reach a way of managing this which she can find acceptable. And in future, if she was sicker, she might even trust me enough to allow me to move things in the direction I want to go and away from the direction she might want to go. And the central of all this is relationship and trust, which is best developed by understanding your patient from their own particular set of values and not trying to impose your own. Kia ora.
Kia ora. Thanks, Ben. And good timing. We've got about 5 minutes to get a little bit more intimate with the audience. There's two rules. One is if you want to ask a question, you need to go to the microphone or just wave out and the microphone will come to you. And that's because we're recording the session, so we want to catch the question nice and clearly. And the second rule is for you, Ben. While that's been a really great conversation, in response to the questions, could you speak in bullet points?
Yep.
Thank you. And you might have a question, you might have a comment, but either way, restrict it to 2 sentences. If you're making a comment, that's fine. Make a comment, and then Ben can reply, or if you've got a question, he can reply, okay? Kaupai, who's got a question? I was hoping that would happen because I've got one, if I could start, if that's all right. So Ben, in one of your slides you talked about ethnic minority doctor, and as that was on the screen, I thought, Ben, you've chosen to be what I think of as an ethnic minority doctor. So you worked in a place where you had lots of Māori patients, and then you worked in Newtown where he told us at the beginning, he said only 15% of his patients are like him. So in your slide you referred to that as being stressful for the patients, but I imagine you're sharing a journey which has at times been stressful for you. You've been working as an ethnic minority doctor.
Thank you. It's really hard to get outside of who you are and not believe that you're right and think about others as being different. And now you've pointed that out, I'm going to try and work out a different phrasing for that. So thank you for that. But you're absolutely right. The risk is, and I'm classic, I'm the, white, middle-class, male, advantaged, academic, the whole bit. I'm the problem, And I find it really hard to always be careful with my language and to be thinking about it from the perspective of the sort of person I might be talking about. So I think the point you make is absolutely true, that as an ethnic minority doctor, yes, it is more stressful for me. However, it's been so much fun. I've learned so much as a result of being open to that and being able to deal with it.
Okay, thank you. Other questions?
I thought that was quite interesting that you just said you were the problem. I suspect that a lot of people react to being told that they are the problem on both sides of the equation.
Yep. Yeah, and I guess that's part of what I'm getting to, is that and I don't know how many of you went to Tony Fernando's talk, but he described how sometimes with difficult patients, we blame the patient. It's the patient who's the problem. And I think that there's a couple of bits to that. One is that we're in the position of power. And so if the patient thinks I'm the problem, that's okay, my shoulders are broad enough. I need to then work out what to do about that. If I think the patient's the problem, actually I'm copping out, because this is just a difficult consultation. I haven't worked out what skills to use to do the best outcome that I could possibly do. On the broader political front, don't go there. It's much easier to talk about what we're doing on Monday morning than trying to deal with the politics of all of that. But, yeah. Any other comments?
Just a comment, Rawari. Within each culture, I guess, people live in diverse realities, and recognising those are just as important. In the case of Māori, some Māori associate with mainstream Māori society. Their kids go to kohanga, they speak Māori in the home, etc. Then there's others who connect with mainstream itself. Kids might go to private schools, they might have Southern Cross healthcare, and then there's those that are alienated between the two groups, such as urban Māori, who have never had experiences in either of those situations. So I think it's important that those diverse realities are recognised when you're trying to treat people.
Yep, and in a sense that's really well put from the Māori example, and I think that really, what you're really saying is saying someone is Māori and presuming you know what they're like doesn't acknowledge those diverse realities, and that's really the essence of what I'm trying to say. And we caught the Inter-Island ferry the other day, and as we came off the ship I saw one of my patients who's a young woman, and I sort of had a bit of a chat with her, and I asked my wife, so where do you think she came from? She was Somali, but she's been completely rejected by her community because I think she's come out as gay. She's certainly left the Muslim faith, and she works on the Inter-Island ferry, which is not a classic sort of Somali woman sort of job. So, she's Somali ethnicity, but culturally probably identifies much more with the youth culture and with her sexual identity culture and with sailors than she does with the Somali community. So I think it's a really good point.
Okay, so thanks for that, Ben. Thanks for your questions. Thanks for joining and coming closer. encourage you to fill out your evaluation sheets, and we're finishing on time. But first of all, let's thank Ben again. Kia ora.